Thank you so much, sir, for the kind introduction. I would like to thank Dr. Kumarel, sir, and the organizing team for giving me the opportunity to talk in Receptor again. So my talk is completely different to what the previous two speakers were. It's about obesity assessment and therapeutic interventions. So there's been lots of noise levels recently with obesity. The reason being we have wonderful drugs which can help us manage obesity in a better way, because we are evolving into a human being with lots of obesity. So the population is growing more obese throughout the world. It was only a Western problem. Now, even in our country, developing countries and underdeveloped countries, it's going to be a problem. So this is the prevalence in India. So the darker areas, there is higher prevalence, and you can clearly see in South India, we have much higher prevalence than what's happening in middle of India and other places. So the understanding about obesity is also getting better. Previously, we used to think it was just because someone was eating more, it was happening. But now the understanding is that it could be because of epigenetic factors, genetic factors, environmental factors, socio-cultural factors, and along with that, we have behavioral and physiological process. And it's very difficult to control it. Talking about obesity itself will have consumed a lot of space and time because it's limited. I'm not going to talk deeply into that. The main driver behind problems associated with obesity is adipocyte dysfunction. So when we have excess adipocyte, two things happen. We have adipocyte, more fat in our body when there is excess weight. Adipocyte becomes hypertrophied and hyperplasia. So when there is hypertrophy, the adipocytes become larger and lots of inflammatory enzymes get secreted from it. And also, there is lipid overflow where fat gets deposited in other places apart from normal adipocytes, like in visceral areas, and in ectopic fat like in epicardial region, pericardial region, liver, pancreas, and other places, which can also increase inflammation, leading on to various inflammatory response and also insulin resistance. So that's the reason why lots of people develop diabetes and PCOD when they become obese. So one of the way we assess obesity is looking at this excess adiposity. So now the American Association of Clinical Endocrinology has referred obesity as an adiposity-based chronic disease rather than calling it as obesity and obesity-related problem. So it's finding the adiposity is the main way we assess obesity, and there are various ways we assess this obesity. The simplest marker for excess body fat is looking at the BMI, which is body mass index. The way we calculate it is look at the weight and look at the ratio with height with regards to in meter square. So it's kg per meter square. It's very simple to do, and this is what we have been using as a marker for assessing obesity. But the problem is it might not tell us the difference between adiposity and large muscle mass, because the person on the right side, even though the BMI is low, he is clearly not physically very fit. Whereas the other person who's got a BMI of 32, where he will come under obesity, he's got a very better physique and also he's more athletic. So it doesn't differentiate between adiposity and muscle mass. That's a problem we have. But it was interesting when we had a discussion with recent launch of one of the obesity product. The bariatric surgeon pointed out that even when someone has got a BMI of more than 35, and looking at their physique, we can tell whether it's going to be any different or not. The problem happens when someone's BMI is less than 35. That's when we can't differentiate whether the abnormal BMI is because of fat or muscle mass. So we use various ways to assess obesity, predominantly using anthropometric measures like weight and height. So we check BMI with the help of weight and height. Then we look at the waist size. Normally, we use another parameter to look at the ratio of the waist with either hip or height. So now we have dedicated charts which tell us when we need to worry with regards to waist to hip ratio and waist to height ratio. It's better marker than just looking at the waist alone. And now data is suggesting that waist to height ratio, which is very easy to assess, might be a better marker of obesity. So now they have charts which tells us similar to what we used to do with BMI. So as the BMI goes beyond 25 or 30, that's when the risk factors goes up. Similarly, for each height, there is a waist height ratio, which we should be looking at. The reason why I think waist height ratio might be better is Assessing the waist size itself is difficult, and when you're looking at hip size, that's much more difficult. So the metabolic surgeon suggested that the way we need to assess the waist is look at the maximum protuberant side, both in the front, in the side, and the back. That's how you look into the waist ratio. And measuring height is very easy. So this is how waist to height ratio is measured. Now we are also getting methods to assess the total body fat. So simplest way is to look at the measurement of skin fold thickness in arms and neck and other places as well. And now we have help of machines which can tell us to assess this amount of fat in the body, like bioelectrical impedance and other things. And DEXA scan is the most better way of doing it. I think that's a gold standard. So if you do a DEXA scan, it will tell us how much fat a person has. So this bioelectrical impedance is getting better, and this is what has been presented by one of our colleagues from Apollo Hospital in a recent Trendo conference. They have bioimpedance analysis in Greens Road, Apollo, where they use it to assess the body fat analysis. And this is how they give the body composition. They look at the water content, amount of muscle mass, minerals, and body fat mass, and then they give a cumulative picture. And this is how they projected the muscle fat analysis. So they give the weight and they compare it for their BMI, how excess it is or how low it is. And then they look at the skeletal muscle mass and also body fat mass. And then they say how much proportion it's higher than what has been ideal for their height. And so this shows that this particular person's body fat mass is much, much higher than what has been recommended. And based on this analysis, then they classify someone to be obese, balanced, or athletic. So this earliest person had increased weight more than what is recommended, and body fat mass was much higher, whereas the skeletal mass was low. So it's like a C-shaped curve. This is obesity. And when someone has got a balanced mass with normal weight and similar skeletal muscle mass and body fat, it's in a balanced body composition. And the ideal or the athletic one is where the muscle mass is much greater than the fat mass. So these bioimpedance methodology is helping us look into this in detail. So looking into the therapeutic interventions, as I said earlier, the reason why we are having lots and lots of talk about obesity is there are newer therapies available which are helping us manage this condition better. But whatever be the newer therapies, I think we still follow what has been projected in various guidelines from lots of time. So diet, exercise, and behavioral modification plays a very important role. We have pharmacotherapy. If everything fails, we can refer them for metabolic surgeries. We don't call it as bariatric surgery anymore, metabolic surgeries, and they're very effective. So when we refer for further therapies apart from lifestyle modification is if someone's BMI goes beyond 27 with one comorbidities, then we refer them for either surgery or pharmacological interventions. If someone BMI is more than 30, irrespective whether they have other comorbidities like osteoarthritis, diabetes, or sleep apnea, we refer them. We can advise them to follow pharmacotherapies, or we can refer them for bariatric surgeries as well, or metabolic surgeries. So this is our own Endocrine Society of Indian guidelines, which got published in 2022, and I think they're working on a recent update. What they recommended is that we can refer patients to pharmacotherapy if they have comorbidities, even when BMI is between 25 to 27, because we Indians are at much higher risk for developing complications, even at a low BMI, with regards to increased ischemic heart disease and other coronary artery disease and other problems. So beyond 25 to 27, with comorbidities, we can refer them for pharmacotherapy. And if someone's got BMI more than 30, we can even refer them for metabolic surgeries and other amenities which are available to us. So lifestyle therapy, it includes two components: diet, which plays a major role, and increasing physical activity. So normally we advise hypocaloric diet based on the patient's height and also their other comorbid status. Diet is the main reason why people will lose weight. So multiple studies have shown following a good diet pattern allows people to lose weight. And one such program was diabetes prevention program, where more than 4,000 people were asked to follow a good diet, and what they noted was with dietary modification alone, people lost up to 7% of body weight. This in turn reduced the chances of achieving, it prevented them from developing diabetes. So this is all done on patients who are at high risk for developing diabetes. And along with weight loss, when they did 150 minutes of moderate intensity exercise, there was a 58% relative risk reduction in incidence of diabetes. So this is the reason why most of the guidelines recommend us to follow 150 minutes of moderate intensity physical activity every week. But if we want to lose weight, we encourage our patients to do more physical activity, ideally 300 minutes of aerobic and resistance training exercise every week, or at least 60 minutes of physical activity, both aerobic and resistant exercise. We all know that it's very difficult to follow a good diet and physical activity, and when someone follows it, people lose weight, but after some time, they start regaining weight. And this has been, we have seen this in real life, and also most of the studies have also shown this. So this particular study showed that people were able to achieve good weight loss with physical activity and exercise, but after 8 weeks, whether they were in the study or not in the study, they started gaining weight, and it sustained to gain weight. Similarly, this is looking at 29 long-term US studies for 1 year. People lost weight, and when they followed them for up 5 years, they gained 80% of the weight they lost over the period. So it's always very difficult to sustain the weight loss. This is in trial settings, so where people are motivated, they get constant calls, despite that people started gaining their weight. And you can imagine the plight of our patients who doesn't have any of these motivation help to sustain the weight loss. So lifestyle modification alone is not sufficient to maintain the weight loss in most of our patients. The reason being, lots of hormonal changes happen. So when we try to lose weight, we try to suppress the appetite and increase exercise. Despite that, when someone has already got obesity, they have counter-regulatory hormones kicking in to avoid further weight loss. So they have increased hunger-promoting hormones like ghrelin and GIP, and they reduce the satiety hormones like leptin, PYY, amylin, and other hormones as well. So there's always a constant balance, tug-of-war happening between hunger and weight regain when someone tries to lose weight, and most of them will give in. That's what happens. So now we have therapies which can help us achieve this. Previously, we didn't have good pharmacotherapies. We look at what has been available so far. So bariatric surgery or the metabolic surgery was recommended for most of our patients when they had high BMI, because they were able to achieve a BMI percentage of weight loss was about 18% to more than 35%. None of the pharmacotherapies were able to offer that. The maximum they could offer was about 8% or 9%. So things like orlistat and locazepam and other things. Whereas there was a huge treatment gap, but now it's changing. So these are the approved therapies. Lots of things came in, like sibutramine and other things came in, but they were withdrawn because they increase the risk of depression, they increase the risk of suicidal tendency and other reasons. But these are the only available therapies which are in FDA in US. And in India, we have only orlistat as the oral therapy. The phentermine, topiramate, and naltrexone buprenorphine combination is not available in India. And you can see the efficacy is about 10% for orlistat, 11% with phentermine, topiramate combination, and about 6% with naltrexone and buprenorphine patch combination. So now we have injectable therapies, GLP-1 analogs. Previously, we had once daily injection liraglutide, which offered about 5 to 8% weight loss in few of the studies. But what we saw in real life was about 3 to 5%. But now it's changed with weekly injection semaglutide, which is GLP-1 analog, and tirzepatide, which is a combination of GLP-1 and GIP analogs, which is weekly injections. They can help us achieve up to 20 to 22% weight loss. And this has opened the door, and we are having newer therapies on the pipeline. That's what we are going to discuss about. So GLP-1 analogs has been available in the market for more than 15 years. It started with exenatide, I think 2008. Then we had liraglutide. Then we had dulaglutide. And now we have semaglutide and other things are available. the way they work is, they work on the central nervous system by reducing the appetite. It works on the satiety center, so it gets satiety center to be stimulated from the beginning, so people tend to eat less. It increases nausea because it slows down the gut motility, so people tend to eat less as well. And in the pancreas, depending on the glucose intake, it increases the insulin secretion and it reduces the glucagon, thereby getting good diabetes control. So this has been available for a long time. Now with tirzepatide, we also are having GIP analogs, which along with GLP-1, what it does is it reduces food intake and it counteracts the nausea, which typically happens with GLP-1 analog. It also increases insulin secretion and it also increases glucagon in a glucose-dependent manner. So when someone has got hypoglycemia, it allows correction. So it reduces hypoglycemia when we use it with insulin or insulin secretagogues. Along with it, now there are evidences that it can work on adipose tissue as well. It can increase the insulin sensitivity. It can increase the lipid buffering capacity, so it doesn't allow ectopic fat deposition. It increases blood flow to the adipocytes, so it reduces the inflammatory response. So thereby reducing the impact of chronic inflammation which we have with adiposity. So we had fantastic results in the last few years. This is once weekly semaglutide looking into obesity management, not into diabetes. It showed 15% weight loss in step 1 trial. And these are various step trials which they do to look into the semaglutide 2.4 milligram once weekly injections to look at weight loss, whether it's for on its own or along with diabetes management or along with intensive behavioral therapy as well. Whichever we looked at, semaglutide showed significant weight loss, and it was sustained as long as the drug was used. Then we had tirzepatide, which had its first publication with regards to weight loss with SERMOUNT trial in 2022. It showed people lost up to 22.5% of their weight. No other oral therapies or, any other medical therapies have shown this. It was closer to what we are able to achieve with metabolic surgeries. And it was sustained for 72 weeks, and subsequent studies have shown similar weight loss. And now we have head-to-head trials. So Lilly themselves sponsored 2 trials, SURPASS-2 and SURMOUNT-5, where they compared both of them and showed significant weight loss with tirzepatide when compared to once weekly semaglutide, maximum tolerated doses. And this is real-life data which got published in JAMA last year, where they looked at people weight loss when they were newly started on semaglutide or tirzepatide, and clearly showed that tirzepatide was superior to semaglutide with regards to weight loss. So we are getting data with this, and when people did not have diabetes, this is real-life data, people lost up to 18% weight loss. So these are showing fantastic results. And now we are looking at other avenues to use this gut hormones for managing diabetes, obesity. So we have used GIP and GLP-1 so far. Now we are looking at how to use glucagon, amylin, which gets secreted from pancreas, and another enzyme called PYY from L cells in the ileum, whether they can help us get further weight loss. So they're understanding these molecules better. They're looking at how they're able to help us weight loss. And what they have noted, most of them causes appetite suppression, thereby reducing the food intake and causing increased energy expenditure at various tissue levels, and thereby causing weight loss. So they are using GLP-1 as backbone and attaching these various molecules, try to see how they help us manage this obesity pandemic in a better way. So they have got various molecules like this CAG-SEMA, where they attached amylin analog like carglitinin along with semaglutide, and see what happens. Here they are also looking at this PYY agonist, glucagon agonist. So they have retatrutide, which is a triple agonist, where they used GLP, GIP, and glucagon to see whether it helps us people to lose more weight. So the understanding is getting better. So we are looking at targets in the brain. We are looking at targets in the peripheral tissue to help us manage obesity. And there are various phase 2 and phase 3 trials going on with various molecules like various other GLP-1 analogs, or the combinations with GIP or amylin analogs or glucagon RAs and other things as well. And SGLT2 inhibitors, they are also looking on their own with regards to weight loss at various doses, or in combination with GLP-1 analogs. Like there is a study going on with dapagliflozin and exenatide. So this is, there are a couple of molecules which are already have shown data that they're very effective, like this CAG-SEMA, as I said earlier, which is a combination of amylin analog and GLP-1 analog, which is once weekly molecule. What they have noted is both these things causes reduced appetite, reduced food intake, increases satiety, and increase in control in eating. Carglitidine has shown reduction in emotional eating, and semaglutide has shown reduced preference for fatty or energy-dense foods, and food cravings come down dramatically with this molecule. And in study setting, they have shown more than 22% weight loss when they use the combination. It was far better than the individual molecules. Similarly, retatrutide, which is a triple hormone agonist, have shown up to 24.2% weight loss at 48 weeks, and the curve is still dropping. So we don't know how much weight loss they might achieve with this. This is phase 2 trial, and they're going through phase 3 trial. The better way of losing weight and having a sustained weight loss is having bariatric and metabolic surgery. For want of time, I'm not going to go into detail. These are the three major procedures what they do. Either they do a sleeve gastrectomy, Roux-en-Y bypass, or adjustable gastric banding. People lose anywhere between 20 to 30% of their body weight, and it's sustained. With the pharmacotherapy, as soon as the pharmacotherapy is stopped, people start gaining weight. Whereas with this, the weight gain is, if they follow a good lifestyle, it might be delayed quite a long time. Still, people will gain weight, but it's not going to be the same thing what happens with pharmacotherapy. So this is my last slide. So previously, we were used to depend on the metabolic surgeons for giving us optimal weight loss. Now we have fantastic therapies which are available as once weekly injections, which helps us achieve a weight drop which is closer to what we can achieve with metabolic surgeries. And there are lots of newer therapies in the pipeline, and it's going to be interesting times in future. Thank you so much for listening. I'm more than happy to answer any questions.